Our next speaker is Dr. Tim Wilens, Chief of the Division of Child and Adolescent Psychiatry at Mass General and co-director of the Center of Addiction Medicine. He's also the MGH Trustees Chair in Addiction Medicine and Professor of Psychiatry at Harvard Medical School. Tim got his medical degree at the University of Michigan Medical School. I actually met him when he was a medical student, and we worked in the same lab. And I was struck by this guy is amazing. He's brilliant. His medical are all the students at University of Michigan that good? But it turns out, Anyway, we were very glad that he came to train at Mass General and stayed on, and he's really been, kind of a mover and a shaker in child psychiatry. He's triple boarded in child, adolescent, adult, and addiction psychiatry. And his research interests, include the relationship between attention deficit disorder, bipolar disorder, substance use disorders, and pharmacotherapy of ADHD across the lifespan. Dr. Wilens and his team are developing a child resiliency program to meet the demands of preventative early intervention programs that will build resiliency in young people, particularly in transitional age youth, between the ages between 16 and 24, to help them to stave off stress and anxiety. Transitional age youth and behavioral health, where it's happening, is the topic of his presentation. Please welcome Dr. Tim Wilens.
Thank you very much. And I have to say, when I met Maurizio, he has a very positive view of that. We were playing volleyball the first time I met him, and guess who won? So it's great to be here. Michelle and Carol, I just want to shout you out for your extraordinary stewardship for the past 15 years. You're amazing people, and we have all really, really benefited from it. I appreciate it. And I look around, and I see a lot of familiar faces and a lot of people smiling, and I start laughing because of all the fun we've had together. No, not that kind of fun. Legitimate. That was a bad joke. All right, I'm going to just get right to my subject matter. But it really is, it's really great to be here. And today I'm going to be talking about not a disorder or a specific thing, but really an age group that, people here have their kids and grandchildren, and if not that, nieces, nephews, and if not that, hopefully you've been through this stage. And it's sort of transitional age youth, TAY we call them. By the way, I'm not a marketer, because when we actually ask them, do they like to be called TAY? They're like, we don't like being labeled as transitional age youth. We're adults, but nevertheless, we still call them TAY. And what I'd like to do is start just kind of with a typical prototypic case. Joey's a 19-year-old sophomore at college, had some anxiety as a kid, now sort of presents with panic attacks, really exacerbated anxiety, not motivated, not going to class, crying episodes, smoking marijuana frequently, and you're going to hear a lot more about that in the next talk. Some problems with peers, a breakup with a girlfriend, and doesn't think he can continue in college. Now, the parents are aware of some of this, but not all of it. So those of you who have kids in college, I have 2 in college right now, they don't call you with the day-to-day things are going well. It's always during the catastrophes that they can't continue, and so you get a bunch of false alarms. And so this is sort of the case that we're going to use to sort of make some discussions about this. Let's see. Oops, if we can go back there. There we are. So there's a lot of behaviors that are already occurring that are challenging and challenge underlying behavioral health. So for example, interpersonal relations and peer relationships. It turns out data shows that it's actually you have more intense peer relationships in your 20s than you do in adolescence. More peer influence in your 20s than in your adolescent years. There's an increase in a lack of oversight in a lot of the sexual experiences, just high-risk behaviors, bungee jumping, surfing behind cars, doing all these crazy things. Again, you're going to hear a world-class expert on vaping and cigarettes right after me. Dr. Evans is going to be talking about that. And there's also things like video game addiction. It's a huge issue for boys and social media. And why is that occurring, and what do you do? There's driving and automobile ownership, legal issues now. When you're 21, no longer is there things forgiven at that point. And then you worry about health issues, including just general health issues like hypertension, but also sexually transmitted diseases. So I apologize, it's like virtually impossible to see everything on this slide, but what I want to make a point, and that is, during this age of 16 to 26, when you're caring for kids like that, you're actually, turns out, most psychiatric disorders and substance use disorders start by the age of 18 and certainly by the age of 26, 75%. So if you look at kids, look at childhood onset. That's why I'm so interested in being a child psychiatrist. 50% of substance use, 50% of most psychiatric disorders start by the age of 18, and if not then, during this period of time. This is for depression, but it's the same for OCD, it's the same for anxiety disorders, substance use disorders, et cetera, et cetera. So this is an age group where all of these things are starting, and one of the areas we run into is who takes care of this group. There's a lot of concern about, you know, adult psychiatry has reservations about it. Child psychiatry says, you know, they're not 18 anymore. I can only take care of kids. So who is taking care of this group, and what are some of the challenges in taking care of this group? One of the things you'll hear me talk about again is through the leadership of then Jerry Rosenbaum as the chair, he pegged an initiative to really focus our hospital at this age group. And it makes sense for a general hospital where we take care of you from birth all the way through geriatrics. So what about this age range? And this is why we're really interested in it. So people ask the question, why is it that adolescents do adolescent stuff? You know, why were you standing on top of a car as it was driving on the beach? And they'll say, I don't know. I don't know. And you know what? They don't know. I don't know. They really don't know. The guy who did that research is Jay Geed. He's a friend of mine, and it really is that way. But to understand sort of why it is that we get into these behavioral things, let me do a really simplistic, reductionistic view of the brain. This is actually a picture of my brain, and it's been labeled so that I actually know what it is. And what I want to point out is in this part of your brain, if you put your hands over the front part of your brain, of your head, your forehead, that's sort of the executive part of your brain that says, don't do this, don't do that, think about it. So you may disagree with what I'm saying, and I see a few people doing this, but you haven't stood up and said anything because your brain is saying wait until the question and answer period. You also have a deeper part, some people are laughing because they're not going to wait, okay. We also have the deeper reward sections of the brain, which as a child psychiatrist I call sort of the sex, drugs, rock and roll, and emotion centers of the brain, the reward centers of the brain. And those are the parts that get turned on by drinks and sex, and for younger kids, sugar and things like that. The problem is that the deeper parts of the brain, the reward centers of the brain, turn on early in life. I was sitting next to somebody on the flight down here. Their kid was a toddler, and they were trying everything to appease the toddler to keep them in there. They were trying this, and then they bring out the video things, and then they brought out some sugar, which they know is going to last for a short time, and then they're going to pay the price for it. But what were they doing is they're teasing out the reward centers. They're trying to motivate through the reward centers. That starts early. The problem is this takes a lot longer. The executive oversight is a lot longer to develop. And there's competition between those two centers. And if you have disorders like ADHD, this isn't working as well. If you have disorders like bipolar or anxiety in kids, the reward, the sex, drugs, rock and roll, and emotional centers are too active. So there's this intricate balance, and a lot of our treatments are aimed at that. So what you have, again, in adolescence now is a reward center that's revved up. Sex, drugs, rock and roll, emotion. But that frontal inhibitory, which doesn't develop until all the way through 25, and if you're a guy, 50, that isn't yet all the way there. So we're competing with that, and that's why that wins out. So what do we do? First, I am so happy that Maurizio talked about resilience, and I've been talking to a lot of people about it. You know, I feel in some ways as a psychopharmacologist, a medication doctor that's worked across things, I love what I do, but I also on days feel like a thoracic surgeon that if I pull out any more fat from the arteries without talking about lifestyle changes and preventive medicine, that I'm doing a disservice. So I've become very dedicated to helping with teams to figure out what we can do to stop disorders that we know are emerging in childhood from getting worse. So what can we do from an early stage, and what can we do in transitional age youth? And these are some basic things. Teach people how to manage anxiety. Teach them how to deal with this intense frustration that kids 16 to 26 will feel, and how to deal with those mood dips, the times you get those phone calls. How do you manage it? Part 2 is, with resiliency, is also a mindfulness component. So how do you help these kids learn in their own space, meditation, relaxation, and imagery? And I just want to shout out that we just started a child resiliency program. We've been very fortunate through philanthropy to be able to get funds to start this. I'm happy to talk to anybody. There's a lot of opportunities right now. We are going to build a world-class program, I assure you, in child resiliency. We have the core competencies, we have the team, and we're doing it as we speak. So come join the party on that one. And then what are some of the treatment components that we talk about? You need developmentally sensitive assessments. Again, through philanthropy, and thank you very much, we have a TAY program, a special clinic for the treatment of kids who are 16 to 26, a lot of college students, or a lot of failure to launch. A lot of kids who just couldn't go to college. They couldn't go to the military. They couldn't move out. So we have a program that is educating the next generation of adult psychiatrists staffed by child psychiatrists, teaching our adult residents. We have 16 a year. We have I don't know if it's the biggest or third biggest, but it's a large adult residency. We have the third largest child residency, and we're teaching everybody in the hospital who works in psychiatry how to manage this age group, so they get core competencies in managing it. So we realize they're not fully adults. They may have anxiety or other disorders, such as Joey, that have tracked with them. And we also appreciate that there's still ongoing separation and individuation. There's a therapeutic frame that's different in a 22-year-old than there is in a 40-year-old, and you have to understand that up front. Engagement is really challenging. That is the toughest thing, and then if you engage, to retain them in treatment is hard. So you have to accommodate your system to manage that. You also have to be willing to do systems. I'm talking to college guidance counselors. I'm helping to get kids out of certain courses, helping parents around those types of things, and other systems. So you have to be systems oriented. And then I think the most critical is parent and family work. This idea that people hide behind confidentiality because the kid is now 19, you're paying their college, you're paying for their independence, and yet, oh no, you can't talk to me because that's my patient. No, you're all my patient. And until we get there with that kind of an attitude, thank you. Until we get there, the kid isn't going to get well because you're the one who's really taking care of the kid still. So there has to be this fine line. And finally, you have to do things like when to pull kids from college and when do you send them back. I'm going to give you a clinical pearl. Don't send kids back to college if they're still unstable, thinking that when they get back there, their anxiety is going to be better, they're not going to have meltdowns, and their substance use is going to get better. So we work with that. Maybe keep them home. Use the local community colleges or colleges. Once they're fortified, maybe going back to the school is right, maybe a different school is right. Other treatment considerations, we use special motivational interviewing techniques. So we actually engage, connect, we're collaborative. We use very fortified mechanisms to bring them in. We roll with resistance, and we help them develop what do you want. It's not going to help what I want you to do. We have to work with you to develop what you want to do, and that may be just getting to your first therapy visit to work on your anxiety. Like structured briefer therapies. You think they're going to come for individual, twice-a-week, insight-oriented psychotherapies for half a year, they're not going to do that. You're lucky if you're going to get them 3, 5, maybe 8 times. So what kinds of treatments can we do? Group work. If they have substance use, they love groups, they'll do groups. And guess what? You can even do groups online, and they're effective. And in terms of medications, if we're prescribing, and I do a lot of that, I can't give them medicines that if they smoke dope or if they drink are going to cause problems. Clinical pearl. Most of our meds, if you drink, you will get drunk faster and you will have a nasty hangover the next day. So those are the 2 things I say, but we can't give meds that would put you in a precarious position if you use. And the other thing is safe storage. They're sharing them, they're giving them away. You need to remind people, especially if they're using stimulant medicines for ADHD or benzodiazepines. Those are the stimulants, by the way, are the #1 misused prescription drug now. They've knocked opioids out, and they're the ones that we're going after. Parent work, I get confidentiality. You have to work with the kid to get consent, but then you need to work with the parent, and If you're doing that, then you need to make that happen in a way that the parents get it. You can get feedback from the parents. Parents aren't as concerned about what the kid is saying. We just need to hear a lot from the parents. So that idea that you can hide from it, you don't need to. There are many ways to manage that. Lifestyle changes actually work really well in these kids. They actually help. So getting them back to exercise, working on diet, working on their social interactions has a huge impact in this age group, and it really changes how they feel. And I'm going to end with saying that we're also very excited because our department has been moving into technologies, and this is a group that is very technology focused. So with that, I thank you very much for the opportunity to speak.